27, BUN of 9, and a creatinine of 1.1. Calcium, magnesium, phosphorus, transaminases, alk-phos, and albumin and total protein were all within normal limits. He had a BNP that was 19. He had 2 high sensitivity troponins that were both normal, and had a respiratory viral panel that was negative for COVID-19, influenza A and B, and RSV. He had an EKG that was normal sinus rhythm with some left axis deviation and LVH. He had a first-degree AV block and some anterior Q waves, but no acute ischemic changes. And then he had a chest X-ray that was completely normal.
Awesome. Zach, do you mind just restating the actual EO's number again?
Oh yeah, it was 1900.
1900. Okay. So I will say, we have I think an emerging syndrome here. I don't know that too many of the labs help a ton beyond what the eosinophilia count invokes. I think we can think about eosinophilia as being sort of primary, or I think there's we oftentimes learn it in like the primary versus reactive framework. I sort of tend to think about it a little bit differently in these days, which is there are certain primary eosinophilic syndromes. Those could be, for example, organ-based manifestations of eosinophilia, which are usually named diseases, right? We can see eosinophilic esophagitis, eosinophilic enteritis, eosinophilic pneumonia, eosinophilic myocarditis, and sort of looking for these sort of organ-based manifestations with eosinophilia. Eosinophilia can also be secondary to other underlying illnesses. In somebody who's 79 years old, the most common would be cancer. And then you can also see it sometimes associated with certain autoimmune diseases like a vasculitis. We don't have primary features of EGPA at this point, right? There's maybe some wheezing, but we don't have other characteristic features of the vasculitis. So I'm not taking EGPA off the list, but it's certainly not high on the list. The possibility of cancer still exists. As we said, anybody who's over the age of 65 who has slowly progressive organ-based symptoms, we're going to think about cancer. And then the possibility of this sort of organ-based eosinophilic syndromes come up, particularly because we have the lung problems. Individuals can have acute eosinophilic pneumonia or chronic eosinophilic pneumonia. And then there are some chronic infections that can also lead to eosinophilia. Certain endemic fungal infections can do it. And then strongyloidiasis can also do it, though we don't necessarily have super big risk factors here. All of those eosinophilic lung diseases, acute eosinophilic pneumonia, chronic eosinophilic pneumonia, the diagnosis is drastically helped by cross-sectional imaging and occasionally bronchoscopy. The one thing that's worth sort of having in your back pocket is recognizing that chronic eosinophilic pneumonia tends to have a peripheral eosinophilia, whereas acute eosinophilic pneumonia doesn't. And that also maps on with the time frame here. So I think in my mind, the eosinophilia sort of helps to shift our focus, but I think all of those categories of diseases, infections, autoimmune diseases, and cancer are primarily on the list. Knowing what's happening in the abdomen may help us say, okay, this is something that's crossing the diaphragm, of which some of the primary eosinophilic pneumonias are unlikely to do. But I think kind of getting clarity on the abdomen and then seeing what the cross-sectional imaging goes, with sort of those being some of the primary diagnoses on the top of my list right now. What about you, Sharmin?
Yeah, I totally agree with that. The other one that I was thinking about was allergic bronchopulmonary aspergillosis too, that can have elevated EOs, wheezing on exam too. Again, probably less likely than the ones that you mentioned, but I just wanted to put that out there. I think in terms of like a chest X-ray being normal, I think this is the point that like a CT scan would be helpful. Like chest X-ray can miss some subtle findings, not a perfect test. So I think in someone that, has eosinophilia, we're worrying about like the pulmonary and eosinophilia, and we're looking at a differential. It would be really interesting to get the CT imaging to see like, do we see fibrosis? Do we see nodules? Do we see cavitary lesions? And I think that can help us make a bit more progress as well. And interesting enough, there's nothing in the abdomen that is coming up in terms of like labs and imaging, but given like the protrusion and the distension that he has noted, I think getting as you mentioned, cross-sectional imaging makes good sense to me. Although like I agree with you that like vasculitis is a lower on the differential, it's never a bad idea to get a UA just to make sure there's no reds there. Sometimes, we might catch people right before the creatinine starts to get worsened. Again, less likely we don't have the other classic features of vasculitis, small vessel vasculitis here, but UA is an easy enough test to get. Back to you, Zach.
Great. So he did get a CT chest without contrast that just showed some bilateral bronchial wall thickening and centrolobular emphysematous changes. He didn't have any infiltrates or changes associated with like fibrosis or any nodules. And then he also got some pulmonary function tests while in the hospital that showed an FEV1 to FVC of 59%, an FEV1 of 39% predicted. He had positive bronchodilator response, hyperinflation, and air trapping with a normal DLCO. And I'll stop there. That's the last aliquot.
All right. So looking at the chest CT, I'll comment on the chest CT and I'll pass the mic to the pulmonary function test to Jack. So, in terms of we don't really see things that would be as concerning for like nodules. Oftentimes, like, vasculitis, the initial presentations tend to be nodule. We don't see any fibrosis or changes that I often see with people with like eosinophilic pneumonia, acute or chronic, which I don't know what to make of the bronchial wall thickening as much, other than like, oh, does he have some chronic bronchitis there that we're picking up? So I think whenever I think about like bronchial wall thickening, I think circling back to like possible exposures that people have at like irritants comes to mind. And do you want to comment on the PFTs, and then we can go back and forth and talk about what we're most concerned about?
Sure, that sounds good. Just sort of a non-pulmonologist brief review of the PFTs. The low FEV1 and the low FEV1 over FVC ratio, to me, I'm saying, okay, there is an obstructive lung disease present. The bronchodilator response sort of puts us into the asthma or reactive airway disease category. And then the normal DLCO is interesting to me. Oftentimes individuals who have emphysema, part of the pathophysiology of emphysema development is the destruction of the alveolar capillary membrane, which sort of contributes to some of the characteristic CT findings we see, for example, the development of blebs and other emphysematous changes. We don't see that here. We actually see a preserved DLCO, which makes me wonder if how do I say this? If there is emphysema, which it seems like there is on the CT chest, that may not be from the character or the classic smoking-related emphysema, which tends to lead to a reduced DLCO, and there may be other potential insults at play here. And then the other thing that I'm taking note of is the fact that there's air trapping that we see. Air trapping can be seen in a variety of interstitial lung diseases, as well as in some complications of chronic obstructive pulmonary disease, whether that's asthma or the sort of asthma-associated syndromes or other interstitial lung diseases like hypersensitivity pneumonitis, for example. But yeah, I'm curious, Sharmin, kind of where are you taking all of this now at this point?
So I was like thinking about like asthma plus EOs, and I might be anchoring, but the differential that often comes to my mind is like the allergic bronchopulmonary aspergillosis. Oftentimes, people present with this kind of worsening asthma that is difficult to control. And if I remember correctly, I think like the lung findings sometimes they have is not as pronounced. I think there is some findings that are specific, but doesn't have to be, if I remember correctly. And that was like a bronchiectasis, I believe. This patient doesn't have a prior history of asthma. So the piece that we're missing is like whether it is progressing despite better control. But that's something that I would be considering at this point. What about you, Jack?
Yeah, no, I'm totally with you. I think what's interesting here is that the bronchodilator response, I think for me, put me much more in the asthma way of framing this as opposed to COPD, which we tend to see in older individuals. And I'm with you. When I see asthma plus eosinophilia, I sort of run through the list of things. There are some sort of eosinophilic variants of asthma, and those individuals benefit from certain other therapies like anti-eosinophilic therapies in their asthma. But the eosinophilia may also be due to allergic complications of asthma. And as you mentioned, ABPA is one of the primary ones we think about. Imaging findings of ABPA, you're spot on in what you mentioned. Bronchiectasis is one of the hallmarks. And interestingly, it tends to be central bronchiectasis rather than peripheral. The other thing that can sometimes come up is people can have what are sometimes framed as fleeting pulmonary infiltrates. And what that means is that you may see infiltrates on one imaging study, follow-up imaging days to weeks later, they're all of a sudden gone. So almost infiltrates that can come and go here. And I think because of that, as you were saying, Sharmin, it's totally plausible that we're catching him in a sort of infiltrate-free phase of the disease. But the fact that there's eosinophilia, bronchiectasis, on a background of what seems to be a disease that's behaving like asthma in somebody who has been exposed to construction sites and soil and concrete and lots of places in which Aspergillus exposure is high, I think makes me also think about that. The question becomes like, well, where do we go there, right? What sort of testing do we ultimately want to get? I forget what the actual testing algorithm is, but there's a couple of principles that how do I say this? A couple principles that can help us remember how to do this, which is we want to prove that there is actually hypersensitivity to Aspergillus that is present. And that can be done with certain skin tests or looking for Aspergillus specific IgE levels. And then we want to basically prove that there is a huge immune response happening to this as well. And that can also be clarified with the very, very high IgEs. And then sometimes we test it just by actually treating them for it and seeing how they do. So whether or not those will be positive, I think is left to be determined, but it's certainly somebody in whom I think it would be totally reasonable to test for those as a next step.
All right.
All right.
Yeah,
We're so excited to learn from you.
Yeah, great discussion. So he did have testing for the Aspergillus IgE that was normal. And so he got treated with prednisone, bronchodilators, and improved over the course of a couple days. Followed up with pulmonary clinic and was given a diagnosis of like COPD asthma overlap. And he was also discharged on like triple therapy and was doing really well at the time of follow-up.
Awesome. Super cool. What did they make of the elevated EOs? Did they think it was like a red herring?
They thought it was just a component of like an allergic asthma type phenotype.
Cool. Very, very cool. Love a good bread and butter medicine. Jack, any reflections?
No, again, I think I guess I will harp on this same reflection over and over again, which is very rarely are we sort of operating in clinical medicine where we're saying, I know that it's going to be this disease and I'm going to test for this disease and prove it, right? A lot of times we're sort of learning how to navigate a problem space. And I think that problem space in this case is how do we navigate pulmonary disease plus eosinophilia with relatively unremarkable imaging findings. And I think it's probably much more useful for us to have a sort of mental map of what that space looks like than to be able to know exactly where we should go in it anytime we find ourselves in that room. And so I think this case really, at least for me, is helping me build out that mental map of like, oh, when we're in this space, indolent progressive underlying lung disease, the finding of eosinophilia in someone with these exposures. If we were to run this exact same case scenario 100 times, I would bet some of those individuals would have ABPA. Some of those individuals would have something like hypersensitivity pneumonitis. Some of those individuals may have something like another underlying ILD or even chronic eosinophilic pneumonia. Maybe not with these imaging findings, but just with these syndromes. So I think what I'm going through back in my mind is being like, yes, we were close, or we were on the right track in terms of the final diagnosis. But I think more important is like, how comfortable was I with navigating sort of the room that we found ourselves in, and sort of ask myself, how can I get more comfortable navigating that room the next time?
Cool. Oh yeah, I totally agree. Zach, any teaching or any learning from you that you want to share with us?
Yeah, so when when I saw the patient, he was actually admitted to the step down unit and had received like a day of steroids and a day of bronchodilators and wasn't getting better. So I was concerned that he may have like heart failure and this was cardiac asthma, and we had kind of missed that. And so I ended up getting like the BNP and some more testing that was kind of not really suggestive of that. And then I saw the EOs and kind of went down the same pathway that you guys did and ordered some of this other testing for like the Aspergillus IgE and all those other things while I was on night float, and just kind of continued steroids to see if maybe he just had a delayed response since he may have had like an indolent lung disease that hadn't been controlled for a long period of time. And that's kind of what wound up happening, that he just needed needed a little bit more time than most patients with a COPD exacerbation, an asthma exacerbation.
Yeah, I think it's like one thing to discuss these cases in the VMR and then being actually in your shoes and taking care of this patients. And I just like commend you for being on night flows, which I know are busy rotation, and still moving this care forward. I'm trying to think about like what else this could be, what else I would be missing. And yeah, I totally agree with you. If I were in your shoes, I would definitely think about like a HFpEF exacerbation potentially too. So yeah, and thank you so much for sharing this case with us. Very informative, very educational. All right, Ibrahim.
Yeah, so thank you, Zach, for this space, and thank you to Sharmin and Jack as well. Just to make this a little bit more active, I guess. If anyone can share a teaching point that they learned during the session, please feel free to do so in the chat. And so for the teaching points for this session, I think we've started off with the dyspnea and orthopnea. And whenever you come across a patient who's coming in for dyspnea, you typically want to think about cardiac as well as pulmonary etiologies as the main two differentials. And then if you do everything and these turn out not to be the most prominent systems, you can then think about neurological involvement. And then also Jack shared with us an important pearl, which is that if you assess a patient for volume overload and that patient does not end up with volume overload, i.e. they have absence of volume overload, that does not necessarily rule out cardiac etiology. And then Charmaine shared with us that an echocardiogram for this patient would be truly important, especially if they ended up with something like HFpEF. And then for the exposure history, do not actually think about it so much in the beginning. Maybe after you pursue imaging and you get a sense that the patient may be presenting with the primary pulmonary disease, you may want to dig further into the exposure for the patient. And then for the smoking history, I think everyone is familiar with its association with COPD. And then finally, for abdominal protuberance, you want to think about states of matter. And so you have the solid, the gas, and the fluid. And so each of these carry their own differential, and each of these differentials can result in abdominal protuberance. And then Jack shared with us the amazing framework for how he thinks about eosinophilia in patients. And so for eosinophilia, you want to think about it primarily as organ-based. And so some of these patients who have primary organ-based etiologies, so for example, eosinophilic esophagitis, enteritis, pneumonia, they can present with eosinophilia. And then patients who have an underlying disease, so not an organ-based disease per se, but something like cancer, can also present with eosinophilia. And then certain patients with autoimmune diseases, such as vasculitis, can also present with eosinophilia. And finally, always remember that certain infectious etiologies, such as certain fungi and strongyloides, can also result in eosinophilia. For this patient specifically, just because their clinical presentation was not really that significant in pointing towards a specific involvement of a certain organ, we wanted to pursue imaging because there would be certain imaging features that would clue us towards one etiology rather than the next. And the PFTs that were pursued were also significant for this patient, mainly because how they pointed towards an obstructive process and how they helped us in ruling out emphysema with the normal DLCO. And then finally, Jack shared with us that if you have a high suspicion for something like allergic bronchopulmonary aspergillosis, you want to think about it systemically. And so when you pursue diagnostics for something like allergic bronchopulmonary aspergillosis, you want to prove hypersensitivity as well as immune response. And this could be through multiple different pathways, including immunoassays, skin testing, and finally looking into whether or not the patient is responding to the treatment. And with that, I think we're done with the teaching part.
Brilliant, Brian. Thank you so much. Sorry, I think my internet connection is not great. But thank you so much, Brian. Thank you so much, Elena, for scribing, and Zach, what an awesome case. Thank you all so much for joining us. We'll see you next time. Bye.